writer as well. مواهب متعددة. And above all, he's a great friend of mine. He's going to give us a good overview about the recent updates about immunosuppression, keeping with what we've been hearing during the last session. تفضل دكتور هاني.
شكرا جزيلا دكتور طارق على هذه المقدمة. وطبعا أنا بسعد بعد الديبيت الجميل اللي أنا سمعته دلوقتي وبعد الكومنت الجميل من أستاذ الدكتور صبري جوهر. Do we need other immunosuppression or not? فحضرتك you paved the way to me. السلايد اللي قبله بعد إذنك. You paved the way to me. Or do we need really future immunosuppression, or we are satisfied by what we have? This is the question. If you know that 50% of our grafts are lost within 10 to 15 years, so definitely when you transplant a patient who is 15 years old, he will be on dialysis again at 30 years old, but with the current protocols. If you know that we don't control the recurrence of original disease in around 15% of the cases, we don't control the subclinical rejection in many cases, and we don't control the chronic antibody-mediated rejection that is increasingly an important obstacle because of non-compliance, non-adherence, or other factors, you'll feel that this talk is important. So let's embark and see what are the ways to get better immunosuppression tools. Do we have an ideal immunosuppression? Let's ask ourselves. Maybe the cost of development nowadays, the different companies don't have a better trials because the acute rejection has decreased in the first year after transplantation to around 10%. So we don't have a marker telling, an endpoint telling if the new drug is good or not. Again, we don't have identifying the patient who will do well by a specific biomarker, because most of the biomarkers that we are using are very expensive. And I will give one example. Those who are getting the belatacept, for example, if they are CD57 positive, PD1 negative, CD4 positive, they will not respond to belatacept. So where can we do this sophisticated test to choose the patient who is beneficial for belatacept? Another point, we need the new drug to be injectable to get better compliance. Less chronic allograft nephropathy, less cardiovascular risk, diabetes, and as Professor Sabri mentioned, less infection, less malignancy, and what is difficult, less expensive. Because if you spend money to develop a new drug, the drug companies wanted to reimburse that money. This was the introduction just to attract you to what I am going to tell, and I will divide my talk into 3 parts. The first part is, could we modify the available immunosuppressive for better compliance? I mean, the same drugs that we have in the market now, but we will play with them in a different way. And the second part, what is coming in the future? And the third part, for getting a better graft, do we need only immunosuppression, or should we in the future play with other points? Cumulative chronic allograft injury, the need for novel therapeutic options beyond immunosuppression. So let's do the first part. What are the available immunosuppression? Since more than 20 years, most patients are transplanted by Symphony protocol. And most places are using induction, different induction protocols, and many of the protocols are not applied because, as the previous speakers told, each center is tailoring a certain protocol and do not deviate about it. So I will start by the rituximab, which was the debate of the last session, and see if it has a role in the induction. Because, as you know, in the mentor study that has been mentioned soon, it has got a role in membranous GN. Because CD20 is not found on pro B cells or plasma cell, rituximab does not prevent the regeneration of B cells from precursor, does not directly affect the immunoglobulin level, but some studies have reported a reduction in the donor-specific antibody. So we know that it has been used pre-transplant to reduce high level of preformed anti-HLA or ABO antibodies, as well as, of course, the post-transplant rejection if it is antibody-mediated. So there is a role in the rituximab in desensitization, and there are, for example, in the UK, and you know the UK people are very conservative, the Target 1 study, transplant antibody-mediated rejection guiding effective treatment in UK. It's a wild multicentric study, outcome allograft survival at 4 years follow-up, adding rituximab to the standard care of antibody-mediated rejection. So this is an available drug that we can use and may modify the prognosis. Another point that can modify the prognosis and we very rarely use in Egypt is the steroid withdrawal protocol. And I'm speaking mainly for the children and adolescents who need to grow in height, and we don't give them the steroid withdrawal protocol, although we have an evidence from this Harmony study from Germany that it is safe to withdraw steroids early after kidney transplantation, whether you give a rapid ETG or a basiliximab, which is more needed in pediatric ages. And when you compare what happened here in the 3 arms, after 1 week of stopping within a week the steroids, you don't find in the first column a big change in the biopsy-proven acute rejection between those on maintenance steroids, 11.2, and those with rapid steroid withdrawal, 10.6, and those with rapid steroid withdrawal with ETG is also around 10. So almost the same results. So why not in the young ages to withdraw the steroids rapidly? Another thing that we have in our hands now is the mTOR inhibitors, and maybe in the shortcoming we will have also the belatacept. So I will speak about the conversion strategies. As you know, the early conversion strategies, there have been a meta-analysis by Kumar et al., 6 trials of early conversion from CNI to mTORs, and these are the 6 trials. I will not go in details, but you see that when you see to the right of the middle line here, the mTOR inhibitors were effective in the early conversion meta-analysis over 102,057 patients. And acute rejection was also, incidence of biopsy-proven acute rejection was significantly higher in the mTOR groups. I mean, the mTOR group had more acute rejection. Therefore, the trend to go for mTOR alone is not wise because you will get acute rejection. But combining it with a calcineurin inhibitor, as you know, has been practiced in the TRANSFORM study, 2 years follow-up. And the TRANSFORM study also met its key secondary endpoint for non-inferiority of the composite endpoint. Late conversion to everolimus, there was Apollo trial, not from the start, but after some time from the transplantation, switching from this CNI therapy to everolimus or continue current CNI. In both groups, you find in the Apollo no difference in rejection in graft loss, all the best small renal benefit. Now, another drug which is present in the United States since many years nowadays is the co-stimulation blockade, Nulogix. And the question, could it replace the CNI in the next decade? We'll see what is the evidence. As you know, belatacept could be given in injections, and this Espinosa in American Journal of Transplantation in 2016 said that the arm of belatacept has got higher degree of CMV, of BK, and maybe a little bit higher rejection. But still, there is an attractive indication for this belatacept in the recurrent FSGS and in the thrombotic microangiopathy. And I think these two conditions, especially in pediatric ages, are an indication to use this belatacept and recruit it from abroad, because many of our adolescents may have recurrent FSGS and need a solution. They are not adherent, so this drug injectable every 1 or 2 weeks is suitable. And again, the thrombotic microangiopathy would be good. And this is from Vincenti, the inventor of the belatacept. The 7 years follow-up shows that the results are almost 87% and 78% graft survival after 7-year follow-up, which is very good. Up till now, the cost, and there is no comparative study between the belatacept and tacrolimus. Because in this study of Vincenti, you see here, belatacept is compared to cyclosporin, and I think the use of cyclosporin nowadays is much less. So we need a comparative study with tacrolimus. Again, conversion to belatacept in patients with DSA, yes, this is an important study published in 2019 showing that you can use conversion to belatacept in patients with DSA. You will find a better profile. So the conclusion of my first part, so far CNA remain to be the baseline immunosuppression. Conversion from CNI to either mTOR inhibitor or belatacept are feasible in a selected group of patients. Early conversion are associated with better GFR at the price of slight increase of acute rejection. Late conversion to mTOR are safe with no increase of acute rejection, however, with little benefit in terms of GFR. Conversion to belatacept are associated with better GFR and even are possible in patients with low-level DSA. Before leaving this part, I will draw your attention to a study that has not been focused on for a long time, which has called the ADHERE study, using rapamycin once per day and long-acting tacrolimus once per day. So this could be one of the solutions for a better compliance, especially for those patients non-adherent to treatment. Now let's embark to the second part of my talk, which are what are the future immunosuppression. Let's go to the first arm, which is the co-stimulation blockade. Already we have the belatacept, but we have other drugs affecting the anti-CD28 and the anti-CD40 monoclonal antibody. These drugs are still having numerical numbers because they have not released up till now, plus or minus the proteasome inhibitor, bortezomib and carfilzomib, and I will come to these soon. Other agents in clinical trial for delayed graft function are the damn expensive eculizumab and the infliximab, and the agent for desensitization, I will go to them in detail after some time, and I will finish by the cellular therapy using regulatory immune cells, including the one study and the TUSK study from the United States. Let's embark and see what are we attacking. Are we attacking only the T cells? This was the only trend, the old trend. Now we are attacking also the B cells. We are attacking the junction between the co-stimulation pathway. We are attacking all the molecules that are released, like the interleukin-6, and therefore we have plenty of targets here, and I will start by the co-stimulation, selective blockade of CD28. This, in contrast to belatacept, may have less adverse impact on the T regulatory cells, and we have here lalizumab and Efimmune. Again, we have anti-CD40 pathway. We have a drug by Astellas and another drug by Novartis in the development. Regarding the proteasome inhibitor, Velcade, many of us, of course, use it in multiple myeloma and in many of the diseases associated or mimic multiple myeloma, has been used, of course, for desensitization, for the treatment of acute antibody-mediated rejection, and in the experimental protocol of transplant tolerance. It has been shown to significantly reduce anti-HLA antibody level, and the main toxicity is neurologic, which de novo or worsened peripheral neuropathy being common. Therefore, they invented one drug with reduced risk of neuropathy, which is the carfilzomib or the Kyprolis, a second generation of the proteasome inhibitor. But the problem with proteasome inhibitor in this big study published in 2018 by Iskandari et al., did not work in late antibody-mediated rejection. There is no change in the GFR, no difference in the graft survival or function at 24 months. So the enthusiasm for this drug has been abated for the chronic antibody-mediated rejection, of course, and even for the antibody-mediated rejection now it is a late option. Could we have other agents that may delay the delayed graft function? Fortunately, we don't have much delayed graft function because most of our patients are living, not cadaveric transplantation. But when we soon go to the cadaveric transplantation, we will encounter this, and at that time, eculizumab could be a use. Infliximab, which our colleague rheumatologists are using and repositioning it from the rheumatoid arthritis trial, and this is an important study showing in CTOT-19 randomized controlled trial of infliximab or the Remicade induction therapy for diseased donor kidney transplant recipient. It is an anti-TNF alpha, and as soon as we start our cadaveric program, I think infliximab or Remicade will be one of the drugs to be used, although it is now present in the market with the rheumatologists. Do we have other options? Yes. Now we have agents for desensitization, including obinutuzumab, which is the second phase of the anti-CD20. We have the IDIS, I will go for it rapidly. We have the anti-BLyS or the belimumab, which is very famous nowadays in lupus patients. We have the C1 esterase inhibitor, and we have the interleukin-6 inhibitor, tocilizumab and glazakizumab. These became very, very famous in the COVID era because they are using to decrease the cytokine storm. So let's see what are these drugs doing in transplantation. I think these are available drugs, and let's go first to the classic. When you have an antibody-mediated rejection, you do plasma exchange or immunoabsorption session, 4 to 14 sessions depending on the IgG titer, and this is by Federico Oppenheimer, and you see that the titer is decreasing with this successive protocol. But suppose the patient did not respond. You can use the refinement of rituximab, which is the obinutuzumab or the Gazyva, also known, this drug got different name in different generation, but now it is called Gazyva. Fully humanized monoclonal antibody to CD20 on mature B cell, currently approved by the FDA for the treatment of chronic lymphocytic leukemia in combination with chlorambucil. And this study published in the American Journal of Transplantation shows the safety, pharmacokinetics, and pharmacodynamic activity of this drug for the desensitization of candidate for renal transplantation. This patient received two infusion of 1 gram each, followed by 2 doses of IVIG on days 22 and 43. It was well tolerated, and most adverse events were grade 1 to 2 in severity. So, according to this data, it could be used with or without IVIG. The second drug is IDIS, immunoglobulin degrading endopeptidase of Streptococcus pyogenes. It will split the antibody, as you see, and give us a window to go to the transplantation. And the fear is that you may have these antibodies recurring back if you don't follow up your patient with stronger immunosuppression. And this is the curve of imlifidase or IDIS, this novel agent cleaving the human IgG. The third drug is belimumab, the B-cell activating factor, or also known as BLyS1, belongs to the tumor necrosis family again, and is important stimulator of the B-cell survival and expansion. And look to the comparison between the belimumab and the placebo in the number of new antibodies. In the belimumab, in the blue, it is very low, and in the new antibodies, in the red, it is high. So, new antibodies present at week 24 reduced significantly, according to this publication in the Lancet 2018. Another BAF stimulator is atacicept, which is a fusion protein formed from the TAC1, the extracellular domain of one of the receptors for BAF. It binds again, which also promotes B-cell and plasma cell survival and may be useful in sensitized patients with established plasma cells. Now, do we have other solution for complement injury apart from eculizumab that all of us consider it a good drug against blocking the C5, but it's a very expensive drug, as you know. But there is one cheaper drug affecting the C1 esterase. So the plasma-derived C1 esterase inhibitor, or Cinryze, has shown a good promise in some French studies, and clinical trials are underway. This is one example of the study by Le Fauchère group from Necker Hospital in Paris. And you see that this drug, C1-INH, added to IVIG, is safe and may improve allograft function in kidney recipient with non-responsive acute antibody-mediated rejection. Now let's go to the state of art, the interleukin-6 inhibitor. How these drugs act. You see here, interleukin-6 drive B-cell activation and differentiation to antibody-producing plasma cells. So, and this interleukin-6 in the middle in green is doing all these bad effects down, causing differentiation of megakaryocytes, neutrophil, macrophage, B-cell differentiation, T-cell differentiation, and all these. So could we block these by giving tocilizumab or Actemra, glazikizumab or Vitieres, or maybe by JAK3 inhibitor? For a long time we were waiting for the JAK3 until it became a reality soon. Again, these drugs has been repositioned from the rheumatoid arthritis. I mean, our friends in rheumatoid arthritis are using these anti-interleukin-6 since long time. And this is an early publication of Actemra in 2019, assessment of tocilizumab as a potential treatment for chronic antibody-mediated rejection and transplant glomerulopathy in HLA-sensitized renal allograft recipient, a very recent publication. And you see here, when you look to the donor-specific antibody, after 12 months of the use, you see that the curve is going down, decreasing, so it is an effective drug. And good survival at 6 years follow-up, because many people will say, okay, it will be a short acting, but this is a monthly tocilizumab for 6 years, given once per month. Compare the curves here and the longevity of the grafts between the standard of care, which is in blue down here, and the tocilizumab, which is in red in the extreme right. There is a marked difference after 6 years of follow-up. Now, the clazakizumab in late antibody-mediated rejection, between 3 and 120-fold more potent than the tocilizumab, given again by subcutaneous administration monthly, every month. So it could be, Dr. Sabri, the future, giving one drug every month, finished. And we have evidence coming here from 2019 and from 2020, a big trial approved in many parts in Spain, Hungary, United States, and Vitieres study, Imagine study, global trial for chronic antibody-mediated rejection to evaluate it in prevention of antibody-mediated rejection. Now, what about the JAK3? I will concentrate on one drug, the tofacitinib is more selective for JAK3 as opposed to JAK2, and it is the first JAK3 inhibitor capable of prolonging allograft survival. This is non-inferior to tacrolimus. In terms of rejection rates and graft survival, it also showed a lower rate of hyperglycemia, but a trend toward more infection, including CMV and polyomavirus. This is in your favor, Professor Sabri, that this drug may cause more infection, but the others did not do that. What about the cellular therapy based on regulatory immune cells? We have, of course, all type can be used in this one study. Polyclonal Treg, antigen-specific Treg, tolerogenic and dendritic cells. And these are the results of cell therapy trial. The one study from the these are the UK data, aimed to produce distinct population of hematopoietic regulatory cells and showing that no cell infusion-related adverse event, no biopsy-proven rejection were observed. All patients have stable transplant function. Median latest serum creatinine was normal, between 90 and 176 in this standard unit. Could we treat the antibody-mediated rejection by certain consensus or by a certain protocol? Yes. These are the recommendations for the TTS published in 2019. I will not go in details of them because of the time, but I will just jump to the last part of my talk, which is, do we have anything beyond the immunosuppression? I need 1 more minute or 2 minutes, please. All this time I was speaking about immunosuppression. But do you think that the chronic allograft nephropathy is a story of immunosuppression only? No, because when you see what's happening here in these biopsies, you see that you have much fibrosis. You may have interstitial fibrosis, tubular atrophy. You may have some effects from calcineurin inhibitor toxicity. The donor age, the donor quality will affect. The pre-existing DSA will affect. So we need solutions beyond the immunosuppression. And among these solutions, we have the different therapeutic options, like management of cellular and antibody-mediated rejection, as I just mentioned, personalization and optimizing immunosuppression, like my colleagues just mentioned in the previous session. I mean, not every patient taking the same protocol, not all our transplant taking the same protocol, definitely. And what I will detail is the anti-fibrotic intervention and avoiding a bad start by choosing bad patients. What are the anti-fibrotic intervention and why they came back to from the grave? Simply, this TGF-beta was not used for many years, but when our colleagues in ophthalmology and in oncology started to use them, the last drug used in glioma, the other one in cancer, the third one from the bottom in pulmonary fibrosis, the perfenidrone in FSGS and diabetic nephropathy and pulmonary fibrosis. Again, nephrologists asked why all the time we should borrow the drugs from rheumatology or from other branch. Okay, let's use again this idea, this very good idea of trying to dissolve the fibrosis by anti-TGF-beta. And another brilliant idea, the senolytics. Professor Tariq Elbaz is pioneer in this, and it has been used in many studies. I will just mention 1 or 2 drugs here used in, last slide, this is the last. These senolytics will try a QP1002 targeting ال P53 anti-senescence ضد الشيخوخة. واللي بعده تحت single injection in cardiothoracic surgery helps prevent acute kidney injury. عشان بيجيبوا لنا العيانين الكرياتين بتاعهم 2 وهيدوهم صبغة وخايفين ان يجي لهم acute renal failure. This is the safety and tolerability of intravenously administered small interfering RNA post on pump cardiothoracic surgery in patient at risk of acute kidney injury, and with marvelous results. And last study here from Mayo Clinic, hit and run, only 3 days of therapy by combination of 2 senolytics مع بعض, dacitinib and quercitidine, and the results were fantastic. The future carries much, and I think the next generation will have better tools, but the present generation can use or modify the available immunosuppression in a better way. Thank you very much.
Thank you very much, Professor Hany, for a rather panoramic overview about everything.
Thank you.
Now we've been talking about so many drugs. In your personal view, which of all what you've been saying do you think is more favorable or will proceed? I mean, the anti-proteasome or the B-cell depleting drugs?
Yes.
Or whether it is the anti-leukin-6 or maybe a mixture of all of these together, 1 or 2, just like
Thank you very much for this question,
now.
but I think we can start by using rituximab more in induction, by using a combination of a long-acting, for example, tacrolimus with a long-acting mTOR inhibitors for better compliance.
You're talking about all patients? Or
I mean in the available patients, especially those non-compliant.
Yeah.
And of course, we can try to bring the belatacept to Egypt, trying to use it in recurrent FSGS that we encounter frequently, and for the cases which non-compliant and needing injectable antibiotic. This is part one. Part two, for those who I'm afraid from the antibody-mediated rejection, I think now we have this Gazyva, which is a good improvement of the rituximab. We have again the belimumab, which is a drug of choice in lupus nowadays, available. Could be used very easily with minimal side effects according to many studies, Melista. And we can use, of course, the era of interleukin-6, which is already available in the market in all the hospital, giving it for COVID. So why not to give it also for our resistant antibody-mediated rejection in our patient? And of course, we should not forget the classic pathways according to this recommendation, going by what? By the plasmapheresis and the IVIG for starting, but I think we can, these are the very promising drug. I don't have much enthusiasm for those drugs cleaving the staphylococcus. I think it will recur after that. And I don't have much enthusiasm for the cell therapy, because this cell therapy, you cannot control the proliferation of these cells. They may increase in a way that may cause malignancy in the future. So I'm not very enthusiastic for this, but I think the interleukin-6 will have a future, and the B-cell control will have a future.
So it's going to be a type of tailored therapy and individualized according to medical patient, right?
Yes, of course, individualization is the key.
If someone has just one question, because we're very short on time, only Professor Sabri, please, تفضل.
Professor Hany, what do you say about converting all these monies spent in all the money, which is costed in inventing, all the money used for creating a classic, an ideal immunosuppressive drug. What do you say about converting all this money for drugs or methods, ways to make tolerance is inactive, and or cloning of organs that do not need at all immunosuppression? I mean, all this money should be paid for investigations related to tolerance, induction of tolerance.
Yes.
Or cloning, which does not need cloning of organs, the same HLA and other genetic characters of the same of the recipient, and will not need any immunosuppression or any tolerogenic.
Thank you very much for this very important question. Of course, Professor Sabri, you know that they are trying to hit many things in the same time. These are the research going in the direction of prolonging the graft survival. I mean, already we did a cadaveric transplant, and we want this transplant to live for a longer time. So we are giving this immunosuppression or these antifibrotics. But what if we don't have a graft from the start? We'll go to the xenotransplantation, as you mentioned, as a way to overcome the shortage of organs. We'll go maybe to the engineering of organs by different printer procedures and put cell therapy cells inside to proliferate, which is another direction in the research. We will go to trying to promote the tolerance, although I'm not very enthusiastic for the tolerance protocols, because if you remember, Professor Sabri, many people from Lebanon who are working in Boston, Dr. Mohammed Saigh and others, worked for many years trying to find this tolerance. And when the mTORs came at the first days, they said that they will solve the story of tolerance, but none of this has been proven. And also some of the drugs, the campus, for example, in induction, when it has been introduced to the nephrology community, they said this is the drug which will cause tolerance. And none of this proved to be, so it seems that the tolerance studies are weak. But let's hope that the xenotransplantation, as you know, will go further. And of course, we are also looking for this solution of a bionic small kidney for dialysis that professor who came 2 years back in our Congress and explained how it will be a small kidney that could be put and overcome the need for chronic hemodialysis. Thank you.
Thank you very much, Professor Hany. Thank you all for your attendance.